Hi, I'm Dr. Koratala from Medical College of Wisconsin, USA. In this lecture, I'll talk about VExUS, that is VExUS Doppler ultrasound. I do not have anything to disclose. When assessing a patient's hemodynamics at the bedside, we pay attention to three important components of the hemodynamic circuit. First, we want to make sure the forward limb of the hemodynamic circuit is good, meaning the stroke volume, cardiac output, and mean arterial pressure are adequate. And then you look at the backward effects of elevated cardiac pressures. For example, elevated left atrial pressures are manifested in the form of elevated extravascular lung water. And elevated right atrial pressure is transmitted backwards into the organs, leading to congestive organ injury. Normally, you use inferior vena cava to estimate right atrial pressure. And you can also use Doppler ultrasound to look at the abdominal veins, such as hepatic vein, portal vein, and renal parenchymal vein, to assess the blood flow at the organ level. That's essentially the VExUS, and that's what we are going to talk about in this lecture. And when you look at the organ perfusion pressure, which is the end goal of assessing hemodynamics and trying to optimize them, the perfusion pressure is the difference between inflow and outflow. For example, the global kidney perfusion is the difference between mean arterial pressure and central venous pressure, that is right atrial pressure. Or you take it as intra-abdominal pressure when it's elevated. So the central venous pressure is essentially like afterload of the organ. So even if the mean arterial pressure is well preserved, if the central venous pressure is offering resistance to the kidney flow, the perfusion is ultimately impaired. So what are some consequences of venous congestion? And venous congestion can be because of pressure overload or volume overload, as in it can be because of chronic severe pulmonary hypertension or volume overload. But for the purpose of this lecture, we focus primarily on volume overload. So what are the effects of volume overload on various organ systems? In lungs, it leads to impaired gas exchange and increased work of breathing. In the heart, it leads to conduction abnormalities, impaired contractility, and impaired relaxation. In the brain, it leads to impaired cognition and delirium. And some of the ICU delirium could very well be because of congestive injury of the brain. And in the GI tract and the liver, it leads to impaired synthetic function and cholestasis, and also malabsorption and ileus. And in the skin and connective tissues, fluid overload leads to poor wound healing and pressure ulcers. So what is VExUS? VExUS, or VExUS ultrasound grading system, involves assessing the rightward limb of the hemodynamic circuit by inferior vena cava ultrasound, which is a traditional parameter used to estimate right atrial pressure. And in addition to that, you use hepatic vein Doppler, portal vein Doppler, and intrarenal or renal parenchymal vein Doppler as an adjunct to IVC ultrasound, and assess the flow at the organ level. And by using all these parameters, we calculate a score, the VExUS score, which we will talk about towards the end of this lecture. So IVC is the first step. And IVC is nothing but a tube that's connected to the right atrium. So it works like a pressure gauge to the right atrium. And here is the inferior vena cava on grayscale ultrasound. So here is an anechoic structure, because blood-containing vessels appear anechoic on ultrasound, and which is joining the beating structure here, which is right atrium. And more precisely, this thing here is the right atrium. And here we have hepatic vein joining the inferior vena cava. So in a spontaneously breathing patient, intrathoracic pressure drops during inspiration, so inferior vena cava collapses with inspiration. And you also look at the maximal diameter of the IVC just beneath the junction of hepatic vein and inferior vena cava, which is somewhere here. So during expiration, you get the maximal diameter, and you assess the percentage collapse with inspiration. And in adult patients, normally we take inferior vena cava size cutoff as 2.1 centimeters. So if the IVC is less than 2.1 centimeters and collapses by more than 50% during inspiration, you take it as normal right atrial pressure. And in children, it's difficult to have absolute values, because as children grow, IVC maximal diameter varies. So you compare the short axis anteroposterior diameter of the IVC with that of aorta and make a ratio. Here is a nice example of short axis view of the inferior vena cava obtained in the subxiphoid view, and this is the anatomic correlation. So this is the inferior vena cava, this is the aorta, and ultrasound beam is coming anteriorly. So anteroposterior diameter would be something like this. And in the sonographic image, you can see that IVC is more or less an elliptical structure, and anteroposterior diameter would be this, which you would compare to that of aorta here. This thing in the middle is the vertebral body with vertebral shadowing. Remember, stones and bones give shadowing on ultrasound. So, and this is an interesting study in adult patients. So in adults, because we have this size cutoff, all the Doppler echocardiography laboratories use only the longitudinal view of the IVC. So this study found that the correlation between the inferior vena cava diameter and the right atrial pressure is actually much lower when you use long axis alone compared to using isolated short axis, compared to when you take a ratio of short and long axis. So it's always a good idea to evaluate IVC in both axes. And as you can see in this graph, IVC, when the right atrial pressure is normal, it's relatively elliptical. And as the right atrial pressure increases, it becomes more and more circular. So the more circular is the IVC in transverse axis, you can assume that the right atrial pressure is getting higher, in addition to looking at collapsibility. And in children with dehydration, a cutoff of less than or equal to 0.8 of IVC to aorta ratio has shown to correlate with low right atrial pressure. So coming back to the VExUS. So here is a landmark study which was done in adult patients in Canadian cardiac surgery cohort. So what they found was when the IVC was dilated, which was more than or equal to 2 centimeters, if these patients had severe Doppler flow abnormalities in at least 2 of the previously mentioned veins, that is hepatic vein, portal vein, and intrarenal vein, then the risk of developing AKI or acute kidney injury was significantly high with a hazard ratio of 3.69. And a word of caution that IVC of more than or equal to 2 centimeters is not necessarily uniform. It may or may not be applicable to smaller Asian patients because this is coming from Canada. And also, obviously, as previously discussed, it may or may not be applicable in children. It might be worthwhile to look at the IVC in short axis and look for the shape and compare it with aorta. And now you may ask, you said, elevated right atrial pressure itself is bad, right? So elevated CVP is like organ afterload. And why can't we just use that? Why should we do additional Doppler studies? They looked at that too. They compared the post-test probability of having AKI when they took central venous pressure alone, when an elevated CVP of more than or equal to 12, they compared that with severe grade VExUS, and the post-test probability of AKI was much higher in this case. So VExUS provides an add-on value to right atrial pressure in predicting organ injury. And not only that, these waveforms are so dynamic and change with therapy in real time. That way we can use them to monitor the response to the therapy that we are giving. And what transducers do we use to do VExUS? Is I prefer abdominal probe or the curvilinear probe for any abdominal application, because all this IVC, hepatic vein, portal vein, and intrarenal vein, all these things are in the abdomen. This curvilinear probe gives better images. But if you don't have, it's fine to use the phased array or the cardiac probe. And we use both color Doppler and pulsed wave Doppler to do VExUS study. Why do we use color Doppler? Essentially to identify the vessels. So color Doppler tells you that there is flow or there is no flow. And if there is flow, what is the direction of the flow? So if the blood is flowing towards the transducer, that's represented as red color. And if the blood flow is away from the transducer, that's represented as blue color. It has nothing to do with artery or vein. And you can remember that with the mnemonic BART, where blue is away and red is towards the transducer. And usually when you look at this color scale, the top color would be red and the bottom color is blue. So whatever is on the top, that represents blood flow towards the transducer. And that's a standard convention. And sometimes you can revert the scale and you can make it appear like blue is on top and red is at the bottom. So in that case, this mnemonic reverses, where red becomes away from the transducer and blue becomes towards. But you typically do not play with those settings when performing VExUS, and just leave it in the standard preset. And what about the pulsed wave Doppler? When you turn this mode on, you get a line like this with a small opening that's called the Doppler gate or sample volume. You place that sample volume on the vessel of interest and you get a velocity tracing. So you have a baseline, and on y-axis there is a velocity scale, there is positive scale and negative scale. And the blood flow towards the transducer, that means like red on color Doppler, is represented above the baseline. And the blood flow away from the transducer, which is like blue on color Doppler, is represented below the baseline. That's how pulsed wave Doppler is represented. And you're primarily evaluating the waveform itself and not dealing with absolute velocities. One thing to note that is that if you're really relying on absolute velocities, you need to get a parallel angle, which means the ultrasound beam direction and the blood flow direction should be parallel to one another. That's when you get the best absolute velocities. But if the blood is flowing like this and ultrasound beam is intersecting like this, you get falsely low absolute velocities. It's something to note when performing any kind of Doppler study. And because we are assessing blood flow patterns, and blood flow patterns occur during systole and diastole, it's important to identify the phases of cardiac cycle accurately. For that, having a simultaneous EKG helps. And when I say EKG, I'm talking about the EKG that's connected to the ultrasound machine. This is the ultrasound machine here. Usually it has a slot for the EKG cables, and EKG cables, these are usable with ultrasound machine only. And you just need to connect the limb lead. So right upper extremity, left upper extremity, and right lower extremity, and you're good to go. You're going to get a tracing on the ultrasound screen. And coming to the anatomy, you're looking at hepatic vein and portal vein in the liver. So IVC is somewhere here, and these three are the hepatic veins. So you have right hepatic vein, middle and left hepatic veins. Usually middle and left hepatic veins form a common stem and join the inferior vena cava. And whenever you're not sure like what vessel you're looking at, you try to trace it down to the inferior vena cava. That would be hepatic vein. And portal vein is formed outside of the liver at the porta hepatis by the junction of superior mesenteric and splenic veins, and it enters the liver at porta hepatis and divides into right and left branches. And if you are not sure if you're looking at portal vein or not, trace it down. And if you are able to go to the porta hepatis and the gallbladder area, you are dealing with portal vein. And usually portal vein has thicker walls or brighter walls compared to hepatic veins. And here is a nice example of the right or middle hepatic vein seen from the lateral aspect. So you scan from the lateral aspect, that is the right upper quadrant. You get the better VExUS images whenever possible. And some patients might have surgical bandages on the lateral aspect or whatever. Then you can get from the subxiphoid view, like from the standard IVC view, you can find the hepatic vein there. And in this image, the probe is in the lateral aspect. There is a probe is somewhere here. And you're looking at the hepatic vein and IVC with the beam coming from this side. So first thing that ultrasound beam would encounter is the hepatic vein and ultimately joining the IVC posteriorly. So IVC is somewhere here, and the hepatic vein is draining the blood into IVC. So because the blood flow is away from the transducer or away from the ultrasound beam, it appears as blue on color Doppler, which means most of the blood flow in the hepatic vein must be below the baseline on spectral Doppler, that is the pulsed wave Doppler. And here is a portal vein, an excellent image showing portal vein coming into the liver and dividing into right and left branches. For these images, I use something called B-flow imaging that's not available on all the machines, but it's just to delineate the vessels for demonstration purposes. Don't worry about that thing. And the ultrasound probe is here, so the blood is flowing towards the ultrasound probe. So on color Doppler, portal vein appears red in color. So how does hepatic vein Doppler appear? And as I just mentioned, hepatic vein is usually more or less blue in color. because the blood flow is away from the transducer. And on pulsed wave Doppler, most of the flow is below the baseline. And it has several distinct individual waveforms. We will see what they are in the coming slides. And yeah, this is the probe position. So right upper quadrant with the probe orientation marker towards patient's head. And you rotate the probe slightly such that the orientation marker is facing slightly posterior. And with slight probe rotation anteriorly, most of the time you'll be able to find both hepatic and portal veins in the same window. So hepatic vein is carrying blood away from the transducer and joining the inferior vena cava somewhere here. And the portal vein is coming from outside the liver, carrying blood into the liver. And ultimately it's going to divide into right and left branches here. So this is the left branch of the portal vein. So yeah, portal vein is red and hepatic vein is blue. That's one way of identifying, but that works only when the patient is normal, right? If the blood flow is reversed for whatever reason, when you're dealing with abnormal patients, that doesn't work. So know the anatomy properly and also know that the portal vein has thicker walls. And here is another nice example. You see inferior vena cava here, hepatic vein, and portal vein. So let's look at the individual waveforms now. So how does a normal hepatic vein waveform appear on pulsed wave Doppler? And IVC is here and it's going into the right atrium. So we are primarily looking at the backward effects of the right atrium, right? So if the right atrial pressure is elevated, it's going to go backwards into the IVC, into all those organs, and I mean, obviously into the liver through the hepatic vein. And you have distinct waveforms in the hepatic vein waveform, which is A, S, V, and D. How these waves are formed. So first one is the S wave or the systolic wave. Systolic wave is formed during ventricular systole. So what happens during ventricular systole is this is the tricuspid annulus here is moving towards the cardiac apex, making more room in the right atrium. So there is more blood going into the right atrium. So more blood going into the right atrium means more blood is going through the hepatic vein into the IVC, which is away from the probe. So you get a negative deflection, that is S wave or systolic wave. And towards the end of the systole, your tricuspid annulus is coming back. So pressure in the right atrium is increasing again. So you have a deflection going upwards, which is the V wave. As shown in this image here, the V wave can be below the baseline, or as in this example, it can touch the baseline and actually go above the baseline too. And both things are normal variants. It's fine. V wave is just a transitional wave between systole and diastole. And here is the D wave or diastolic wave. During diastole, the tricuspid valve is opening, so more blood is going from right atrium to right ventricle. Now there is more room in the right atrium. So there is another bout of blood that goes from hepatic vein into IVC into the right atrium. So you get another negative deflection, that is D wave. Normally, S wave is bigger than that of D wave. So the amplitude of S wave is bigger than D wave. That means there is more venous return going to the right atrium during systole than diastole. Remember this because it's important when the right atrial pressure is elevated, this relationship is going to be reversed. And the final wave is the A wave. Towards the end of the diastole, you have, there is no more room in the right atrium because the right atrium has already filled throughout the diastole when the tricuspid valve is open. And now there is a little bit of atrial contraction towards the end of the diastole. When the atrium contracts, there is elevated right atrial pressure, pushing the blood backwards a little bit. So that gives you the A wave. So normally A wave is pretty small, and A wave is small, and V wave is most of the time below the baseline. If at all it's there, it's a little bit above the baseline. So majority of the flow is still below the baseline in the hepatic wave. So most of the flow is still blue on color Doppler. And as I said before, it's very important to have simultaneous EKG to be able to know which wave is what. For example, if the V wave is above the baseline, right? So you have two above the baseline waves and two below the baseline waves, especially if V wave and A wave are slightly bigger, it creates confusion. Is this A wave, S wave, V wave, and D wave, or is this V wave, D wave, A wave, and S wave? We don't know unless you have EKG. So let's see the EKG hepatic vein relationship. Here is the relationship between EKG on top, CVP, and hepatic vein. And CVP and hepatic vein waveforms are essentially the same. The X descent and Y descent of CVP correlate with S wave and D wave. And A wave of the CVP is like A wave of the hepatic vein. And you also have this little bit of C wave in the CVP because of tricuspid closure. That's not very well seen on hepatic vein. And sometimes you see a small blub here, which corresponds to the C wave. Sometimes you call it S1 wave. That's normal, but most of the time you don't. And so here is the EKG. So the mechanical activity or the blood flow follows electrical activity, right? So you have one wave on EKG first, and then the flow follows that. So A wave follows the P wave, and S wave follows the R wave, and D wave follows the T wave of the EKG. And that's how, when you have simultaneous EKG, it helps to identify the phases of cardiac cycle. So this is what happens to hepatic vein waveform when the right atrial pressure is increased. So normally we said that the amplitude of the S wave is bigger than that of D wave. That's normal. And here is the A wave. And as the right atrial pressure increases, there is more resistance to the blood offered during a systole. Because during diastole, anyways, the blood has to flow, right? Because the tricuspid valve is opening and there is more space. Except, I mean, there are certain exceptions, but in general, that's how it works. And also, when there is fluid overload or a lot of pressure overload, this is associated with some degree of tricuspid regurgitation. And you can imagine that during ventricular systole, the tricuspid jet is going back into the right atrium, right? So here is a right ventricle, here is the right atrium. So if there is a tricuspid regurgitation during systole, it's pushing the blood back into the right atrium during systole. That means it's offering more resistance to the systolic wave. So systolic wave becomes smaller and smaller, and the ratio is inverted. So S wave becomes smaller than D wave, and with further increases in right atrial pressure, S wave goes above the baseline and sits along with A line here. This is A, S, and D. And ultimately, all the above the baseline waves fuse and form just one systolic reversal wave, and followed by D wave. You call this S reversal or just a D only pattern. But D only pattern essentially indicates severe flow abnormality in the hepatic vein or severe congestion. So here is how EKG helps. So this first image, if you see without EKG, just if you look at the waveform, it appears there are two waveforms in each cardiac cycle, right, below the baseline. You might think both S and D are below the baseline, and actually S probably seems to be slightly bigger than the D. It's probably normal, but it's not. If you closely observe, this is the QRS complex, right? So there is no wave immediately following that. And this is the T wave of EKG, and the D wave is following the T wave. And here is another D wave following the T wave, D wave following the T wave. And there is no wave here immediately following the QRS complex. So this patient had atrial fibrillation and irregular rhythm. So when patients have these rhythm abnormalities, having EKG tremendously helps. So without EKG, you would think probably it's almost normal waveform, but with EKG, you know that this is severe congestion and there is no S wave here. And here is another nice example where you see diastolic wave is starting here in one part of the cardiac cycle, extending over the QRS complex of the next cardiac cycle and going till the next T wave. So this is the fusion of D wave and S wave here. So we don't see A wave in between, but you see the V wave. So S wave of one cycle and D wave of the previous cycle are fusing with one another. So this fusion can also be mistaken. So if without EKG, if we just look at this waveform, it appears like there is one waveform above the baseline and one below the baseline. It can be mistakenly interpreted as D only pattern or S reversal. So in this case, actually the opposite of the first case, this patient wouldn't be congested at all, and you might think this patient is severely congested. And this kind of fusion typically occurs when the patients have atrial fibrillation or just hyperdynamic circulation. So this patient had hyperdynamic heart for whatever reason, and the waves are fused. And how about this one? This looks so normal, right? So this waveform looks essentially the same as the previous example that we showed. So like this waveform, right? So S, V, and D, and A. And let's go back to that wave. So it exactly looks like that. This seems like A wave, S wave, D wave, like a normal waveform. But let's have EKG and take a look. So if you have EKG, you have QRS complex here, and this is the S wave, not the previous one. So this is the V wave, and this is the D wave. So S is less than D here. So this patient had, at least mild congestion. So this is not completely normal. That's what I'm trying to say. That without EKG, you can make several mistakes in interpreting hepatic vein waveform. Another thing to note is that hepatic vein waveform exhibits respiratory variation. Here is a very nice example in this patient with intermediately elevated right atrial pressure, meaning IVC is big, the maximal diameter is big, but it's collapsing almost 100%. So you call it intermediately elevated right atrial pressure. But that's not the point. You can see that how much respiratory strength this patient has, or like strength of breath. During inspiration, both the S and D waves increase in amplitude. That's because there is more venous rhythm going into the heart. And during expiration, these waves become small. And this I put this up example because it very nicely demonstrates the difference between inspiration and expiration. In all normal patients, it won't be like this, but this patient had tremendous strength of breath. And coming to the next vein, that is portal vein. Unlike hepatic vein, which is a direct tributary of the inferior vena cava, portal vein is separated from central venous circulation by hepatic sinusoids. So the right atrial pressure is transmitted to hepatic vein directly, but in between the central venous vasculature and the portal vein here, there are sinusoids which act as resistance sites or shock absorbers. So 100% of CVP is not transmitted to portal vein. So normally the portal vein does not have those distinct S and D waveforms, but it's just more or less continuous. And here is a nice study from 1987 that shows how much percent of CVP is transmitted to hepatic sinusoids, even when the CVP is as elevated as about 13 millimeters mercury. Only about 75 to maybe about 70-75% of CVP is transmitted to them. So yeah, let's see how portal vein appears on grayscale. So portal vein can be accessed through right upper quadrant or from the subxiphoid window. So right upper quadrant, once you find the hepatic vein, you fan the probe slightly anteriorly, portal vein should come into view. And IVC, you should see a little bit oblique view or transverse view of IVC. And you have this portal vein crossing over the IVC and going into the liver. And in the subxiphoid view, once you find the IVC and hepatic vein, you fan the probe slightly towards right, and then the portal vein would come into view like this. So you can use either spots, but again, like my favorite is always right upper quadrant because you get less noise or less interference with the waveforms when you do it from the right upper quadrant compared to subxiphoid view. And as I said, portal vein is red on color Doppler because the flow is towards the transducer. The transducer is here and the blood flow is towards the transducer. And that means on pulsed wave Doppler, the waveform must be above the baseline. And there are no distinct S and D waves, so it's relatively continuous. And sometimes you'll see some dips in between each cardiac cycle, which correspond to A wave of the hepatic vein. And it also exhibits respiratory variations during inspiration. It increases amplitude, and during expiration, it decreases in amplitude. And what happens to portal vein waveform with increased right atrial pressure? So normally it's more or less continuous, and with increased right atrial pressure, it becomes more and more pulsatile. And pulsatility you measure by going to one particular cardiac cycle, take the highest point and take the lowest point in a particular cardiac cycle. You don't want to measure this portion and this portion here because this is probably due to respiratory variation. During inspiration, the amplitude is increasing. So just go and do it in the one cardiac cycle. So once you get the highest and lowest measurements in a given cardiac cycle, it's like ejection fraction. Big number minus small number divided by big numbers. That gives you percent collapsibility. But just visually you can appreciate. I mean, normally it should be less than 30% pulsatile. And if it's somewhere between 30 and 50%, you call it moderately increased congestion. And if it's more than 50% pulsatile, you call it severely congested portal vein. In this example, it's probably maybe 80% pulsatile or something visually. So you can call it severely congested portal vein. And with further increases in right atrial pressure, you even have like flow reversal below the baseline. And it typically happens when it is accompanied by severe tricuspid regurgitation. So during systole, there is reversed flow in the portal vein, like that of you saw in the hepatic vein. During systole, the flow has reversed. Yeah. And one caution with portal vein is that otherwise healthy, thin, young individuals may have pulsatile portal vein at baseline, even without elevated right atrial pressure. And also patients with liver cirrhosis can have pulsatile portal vein without elevated right atrial pressure, because in that case, it's just reflecting local pressures, that is portal hypertension. And here is a nice example of relatively pulsatile portal vein in a case of liver cirrhosis. And also in cirrhosis, hepatic vein waveforms is also blunted. Like you don't see very crisp S and D waves. You see some pulsatility, or you may just see a continuous waveform, like a portal waveform depicted below the baseline. That's how hepatic vein appears in patients with cirrhosis. And here is another case of cirrhosis where the portal vein has become completely blue because there is hepatofugal blood flow, because the blood is flowing away from the transducer completely. And here there is continuous flow, but it's below the baseline. There it doesn't tell you anything about the right atrial pressure or venous congestion. It just tells you that there is portal hypertension. And coming to the intrarenal vein or renal parenchymal vein, we stress on the intrarenal part because you don't want to look at the velocities or blood flow pattern in the main renal vein because it's outside the kidney. And intrarenal veins are within the kidney capsule. The kidney is an encapsulated organ, so if there is a venous congestion, the back pressure is going into the kidney, ultimately leading to interstitial edema and resistance to the venous flow. If you sample these interlobar veins, which are just beside the medullary pyramids, they reflect the parenchymal pressure better, because ultimately this is the cortex and these are medullary pyramids, and these comprise renal parenchyma, right? So if you want to assess the renal parenchymal pressures, you look at the blood flow pattern in the interlobar vessels. You can also do it in the arcuate vessels, but the arcuate vessels angle is not perfect because the ultrasound beam is coming like this, and the blood flow in the arcuate vessels is perpendicular to the beam. As we mentioned before, perpendicular angle is not good in Doppler. You want to get a parallel view or parallel flow as much as possible. And this is how normal intrarenal venous waveform looks like. It's below the baseline because renal veins carry blood away from the transducer. So the transducer is here and the blood is flowing away from the transducer, so it's below the baseline. It's relatively continuous, exactly same as that of portal vein. And on top, most of the time these vessels are small, so you get the arterial waveform on the top. So this thing is a systole, diastole, systole, diastole, systole, diastole. So it's like a built-in EKG. Even without EKG, if there is some flow alteration here, you know during what phase of cardiac cycle the flow alteration is happening. So having a simultaneous arterial waveform is actually helpful. And here is a nice B flow imaging of renal vasculature. So these are main renal vessels here, segmental vessels, and this thing here is the interlobar vessel. That's what you are sampling, because the blood flow is parallel to that of ultrasound beam, and also it's ultimately the renal parenchyma. It's reflecting the pressures within the kidney parenchyma. And what happens to renal vein with increasing right atrial pressure? So like that of portal vein, it becomes more and more pulsatile. And when I say pulsatility, I'm talking more in between the cardiac cycle. So this is systole here because of arterial waveform, this is diastole. So in between systole and diastole, you start to see a depression. That's when the right atrial pressure is increasing. So that's pulsatile intrarenal vein. And ultimately you have two distinct waveforms, one in systole and one in diastole. These are like S and D waves, very similar to that of hepatic vein waveform. It's called biphasic pattern. And with further increases in intrarenal pressures or right atrial pressures, the S wave is reversed. Because of arterial waveform here, you don't see the reversed S wave, but you see only D wave corresponding to diastole phase of the artery or diastole phase of the heart. And this is the D only pattern, again analogous to hepatic vein. It indicates severe congestion. And if you are able to get just the venous waveform without the arterial trace, and here is what it would look like. So here is a systolic wave, V wave, diastolic wave, A wave, S wave, V wave, D wave. It's exactly looking like the hepatic vein wave, right? So these are all systemic veins. They appear the same. The portal is different because it's separated by sinusoids, but other than that, most of the waves look very similar. And with the distance from the heart, it changes a little bit, but overall the waveforms are relatively similar. Now, how do we put all this thing in one place and try to grade the congestion or try to quantify congestion? So you call VExUS grade 0, or there is no congestion if the IVC is less than 2 centimeters. Again, you have to take it with a pinch of salt because it's obtained from a Canadian cohort of adult patients. If you are doing it in children, actually there is no good data on VExUS in children. So if you are designing a study, again, you can't just go by this IVC less than 2 centimeters criteria. You have to look at it in the transverse plane and use your clinical judgment. Same applies to patients, like smaller patients such as Asians, who tend to have smaller IVCs than their Western counterparts. And for grading purposes, each waveform is divided into normal, mildly abnormal, and severely abnormal. Hepatic vein is normal if the S wave is more than the D wave. If S wave is less than D wave, it's mildly abnormal. S reversal signifies severely abnormal pattern. And in the portal vein, less than 30% pulsatility is normal, 30 to 50% pulsatility is mildly abnormal, and more than 50% pulsatility with or without flow reversal is severely abnormal. And in the intrarenal, if you have continuous waveform, that's normal. If you see distinct systolic and diastolic waves, that is the biphasic pattern, it's mildly abnormal. And if you see D only pattern or monophasic pattern, that is flow only during diastole, that's severely abnormal. You call it grade 1 or mild congestion if you have a plethoric IVC and a combination of normal or mildly abnormal waveforms. So any combination of plethoric IVC and any of these waveforms here. And you call it grade 2 or moderate congestion when the IVC is plethoric and you see at least one of these severely abnormal waveforms. And you call grade 3 or severe congestion when IVC is more than or equal to 2 centimeters, that is a plethoric IVC, and 2 or more severely abnormal waveforms out of these 3. So if you have a plethoric IVC and S reversal on hepatic vein and say more than 50% pulsatility on portal vein, you don't even need to obtain renal vein. You just know right away that there is severe venous congestion. And this is the pattern. The grade 3 congestion was the pattern that was associated with highest risk of developing acute kidney injury in the original study. And this can be used in various scenarios. You can use it in iatrogenic fluid overload, heart failure, or anything. And these waveforms are pretty dynamic and you can assess response to therapy. So let's just see one case that summarizes the dynamicity of these waveforms and we'll finish. So we have an elderly woman with heart failure with reduced ejection fraction. Her baseline serum creatinine was 1.2 to 1.4 milligram per deciliter. And the creatinine increased to 2.6 milligram per deciliter with a simultaneous drop in serum sodium to 127. And the patient's diuretic regimen was recently up-titrated. So the treating physician thought the patient looked dry and recently the diuretics were up-titrated, so they held diuretics. What made them think the patient is dry additionally is this thing. I mean, the patient absolutely did not have any pedal edema. And we know that pedal edema and auscultation findings such as crackles are not really that sensitive for detection of significant heart failure. So we can't like 100% rely on them. So you do a physical examination enhanced by point of care ultrasound. You look at the inferior vena cava. It's plethoric both in short axis and long axis. You can always argue that maybe this patient has chronic pulmonary hypertension with such a reduced ejection fraction. So that's fine. I don't argue with that. But now you further go downwards in the hemodynamic circuit and perform VExUS. So here is a hepatic vein waveform. So here you see D only pattern with S reversal. So this is the A, and this is the S reversal, and this is the D. And portal vein is 100% pulsatile with even a little bit of flow reversal. So this is severe congestion of the portal vein and hepatic vein. You know, this is VExUS grade 3 just by now. There is plethoric IVC, D only pattern on hepatic vein, and 100% pulsatile portal vein. And on renal vein, intrarenal vein, this was obtained without the simultaneous arterial waveform. Here you see D wave, and this thing about the baseline is the S reversal. So this also is correlating with severe venous congestion. So this patient was started back on diuretics, and we started on IV diuretics because we believe pulsatile portal vein indicates gut congestion, and IV diuretics might be better in that setting. And there is some data from observational studies. There is no like really hard data on this thing, but it's better to be safe than sorry, you know. And hepatic vein, so this was done with a different machine so that we have simultaneous EKG, and the previous one was obtained with a handheld ultrasound machine, which is good too. But just to show you the changes better, we have this these tracings here. So initially sodium 127, creatinine 2.6, all severely congested waveforms. So we said the assessment plan was that there is severe congestion, start IV diuretic. And on follow-up 2 days later, sodium improved to 132, creatinine improved to 2, and assessment and plan was persistent congestion, continue IV diuretic because the portal vein is still pulsatile. And rest of the veins obviously were indicating severe congestion too. And on further follow-up, hepatic vein has nicely improved, but S was less than D, that is implying moderate or mild congestion. And portal vein has dramatically normalized. And intrarenal vein, instead of D only pattern, you got both S wave and D wave below the baseline, which is biphasic pattern. This is significant improvement in all the waveforms. And simultaneously, serum sodium and creatinine has improved. And we said congestion is improving, portal vein has become continuous, so now you can transition to oral diuretic. On further follow-up, sodium and creatinine normalized, meaning creatinine came back to baseline. And hepatic vein, you can see that the S wave is more than D wave, which is completely normal. And portal vein remained normal, and renal remained biphasic with S and D waveforms. It's not completely normal, but renal tends to lag behind because of the persistent interstitial edema. So the first one to improve is always portal vein because it's separated from central circulation by hepatic sinusoids. And the last one to improve is intrarenal vein. And we also don't know how intrarenal waveform is affected by severe CKD because there are no studies in patients with severe CKD. So here our assessment and plan was obviously improved congestion, and the patient is okay to be discharged with follow-up. So this is how we use these waveforms in real life. So thank you so much, and happy to take any questions. You can reach out to me on Twitter. My handle is nephropy, or through my website nephropocus.com. Thank you.